Hi everyone, welcome to our Muppets Apex Preparation Guide on the approach to the pale child. And for those who don't know me, my name's Elise and I'm the Muppets 2025 Academic Coordinator. We hope that this series is really helpful in helping to prepare you for your end of year Apex History Pluses. And just a reminder that these topics come from the faculty guide as well, so I'd really encourage you to take a look at that while you're watching these videos. Okay, let's get started. Okay, just to run through the contents, which are pretty similar across our Apex preparation guide videos, I'll start off by introducing and defining Pala, then giving you a framework for how you can approach the topic or a couple of frameworks. Then we'll speak through history and examination, including important questions on history and red flags for both. Then we'll discuss some key investigations before going through a couple of differentials as well. Okay, so what really is Pala? And I know when I was thinking about this topic, all I could think of was anemia. But I found this definition, which I think is really helpful. So Pala refers to any condition that decreases the concentration of hemoglobin or alters its distribution of blood away from the body surface, which may present as Pala. So while anemia is likely the cause for most cases of Pala, it can also refer to anything that draws the blood away from the body's surface. It usually is appreciated clinically in the case of reduced hemoglobin when the hemoglobin count is below 90. It can be helpful to think of Pala in terms of four mechanisms. So we have decreased erythrocyte or red blood cell production, increased red blood cell destruction, blood loss, whether that's acute or chronic, and in terms of the non-hematological causes, which are most often acute, and these are going to cause the distribution of blood away from the body's surface. We have respiratory failure, anaphylaxis, hypoglycemia, and sometimes heart failure as well. I often like to present two frameworks or approaches. And the first one that I will discuss is a systems-based approach, which is quite challenging in the case of Pala, because, for example, when I was trying to think about it initially, I thought about hematological being the most obvious, but then struggled with some other systems. But how it can be helpful to think about it is hematological being the most common or the biggest group of causes. And then I thought about gastrointestinal or hepatobiliary causes as well. And they're both non-hematological and hematological systematic causes. So for hematological, iron deficiency anemia definitely being the most common. And other forms of anemia, for example, B12 and folate deficiency, chronic anemia of chronic diseases, which isn't listed, acquired hemolytic anemias as well. Malignancy is also really important to consider. So leukemia, for example, because of that reduced production of all blood cell lines. Disorders of hemoglobin structure and synthesis, so thalassemia and sickle cell disease. Then we have our red blood cell enzyme defects and our red blood cell membrane defects as well. In terms of gastrointestinal and hepatobiliary causes, I guess most of these are due to anemia of chronic disease. In the case of inflammatory bowel disease, it can sometimes be more acute in a flare-up, but it can also be chronic. So blood loss is not necessarily seen. The patient might not report it, seeing it in their stool, for example, but it's chronic blood loss over time. So inflammatory bowel disease, celiac disease, liver, and renal or chronic kidney disease being important causes. And I broke up systemic causes into non-hematological. So these two causes are acute shock and hypoglycemia. And then hematological, for example, DIC, autoimmune hemolytic anemias, hemolytic uremic syndrome, thrombocytopenic purpura, and severe blood loss as well. For example, if that's from trauma. The next approach or framework that I'll talk about is an age-based approach. So I've broken it down into a neonatal type age group, infants and toddlers, and then children and adolescents as well. And the conditions are listed from most to least common as well. So for neonates, blood loss accounts for about 5 to 10% of all severe neonatal anemia. And causes may include hemorrhage, so for example, placental abruption or subgaleal hemorrhage as well. Isoimmunization, so ABO or rhesus incompatibility. Forms of congenital hemolytic anemia like spherocytosis or G6PD. Congenital infection like parvovirus, HIV, syphilis, rubella, or sepsis as well. And then genetic causes of anemia, things like Diamond-Blackfan syndrome or Fanconi anemia, which you don't have to know about, but just can be important to recognize as causes of anemia in the neonate. Then looking at infants and toddlers, iron deficiency anemia is most definitely the most common cause of anemia in this age group. It's often from inadequate dietary intake, but it can also be caused by chronic occult blood loss from Meckel's diverticulum, for example. Infection can be a cause. Blood loss from trauma or GI blood loss, disorders of hemoglobin structure and synthesis, like thalassemia or sickle cell disease, and we have our red blood cell enzyme defects again, so our G6PD. We have our red blood cell membrane defects like spherocytosis and elliptocytosis, and acquired hemolytic anemias are definitely a rarer cause, things like drug-induced anemia or hemolytic uremic syndrome or DIC, so disseminated intravascular coagulopathy, and then not forgetting as well malignancies, so leukemia or myelofibrosis as well, where there's inadequate space in the bone marrow. And in children and adolescents, there is a second peak of iron deficiency, which can be due to inadequate dietary intake or menstruation, obviously being a very important cause in people with uteruses. Chronic disease, so things like hypothyroidism or IBD, celiac disease, renal and liver disease as well. Other forms of blood loss again, so GI loss and, as I said, menstruation. And then the other causes are the same as the infant and toddler age group. Okay, so in terms of history, I guess most of the questions are going to be associated with anemia. And I just put up the top here. It's really important to remember that anemia is not a diagnosis on its own. So think, why is this child anemic? What is causing this child's anemia? And I've put little red flag symbols next to questions or symptoms that are most concerning. So in terms of timing, you want to think about, is it slow and insidious, the onset of the pallor, or did it happen really suddenly? And you've got to consider, is this a life-threatening condition? So, for example, has there been severe blood loss that's happened acutely? Is this child in shock, in respiratory failure, or are they having a hypoglycemic episode? If the child is anemic, considering do they have any other symptoms associated with the anemia? So shortness of breath, fatigue is obviously really, really common. Poor concentration or reduced concentration span at school can be a very commonly reported symptom or reported by parents and caregivers. Dizziness, fainting, and collapse might be reported, particularly in older children and adolescents. And pica, or the consumption of non-nutritive substances as well, things like ice or dirt and sand can be quite common. And then in terms of intake, think about, is there insufficient intake of different nutrients like iron and B12 and folate? So is this child vegan or vegetarian? How much cow's milk do they consume? Because we'll talk about it a bit more later, but if younger children particularly are consuming over 500 mils of cow's milk per day, this can interfere with iron absorption. And how's their intake of green leafy vegetables as well, which is more important in terms of folate. But of course, a lot of breads and cereals these days are fortified with folate, so it's not very common to see. In terms of considering if there's any...
Attention, please.
So in terms of considering losses of blood that may result in anemia, considering the menstrual history in young people with a uterus, and making sure to quantify blood loss in terms of amounts of sanitary products used, considering gastrointestinal causes of blood loss, for example, hematochezia. Is there any abdominal pain or loose bowel motion? So think about IBD, celiac disease. And then considering, does this child have any easy bruising or bleeding? So asking about gum bleeding, bleeding into joints as well can be really important to consider. So do they, for example, have a thrombophilia or a factor V Leiden deficiency, for example? Then thinking about excessive breakdown or inflammation, considering is there any jaundice present? So this could be indicative of a hemolytic anemia. Is there a family history of any blood conditions as well? Is really important. For example, particularly in thalassemia or sickle cell disease. And does this child have any known chronic diseases like celiac disease, any rheumatological diseases like juvenile idiopathic arthritis? Some more red flag features that might be indicative of malignancy, loss of weight that's unexpected, any fevers or night sweats, significant fatigue, frequent infections and easy bruising and bleeding. And then considering the medication history, passing current medications, and particularly those that might cause hemolysis if the child has G6PD deficiency. So it's not just fava beans, as I found out from doing the research for this presentation. So in terms of examination, most children with mild to moderate anemia don't necessarily have any signs or symptoms. And Pala has a poor sensitivity for predicting mild anemia, but it correlates well with severe anemia. So just noting that not all children with anemia are going to have Pala. But on general inspection, you might note Pala generally. The child could be jaundiced if there's a hemolytic picture going on. They might be really listless or fatigued if they're severely anemic. They could be short of breath, so you might note some respiratory distress, use of accessory respiratory muscles in younger children, for example. Vital signs are really important, particularly in cases of acute blood loss, and blood pressure and pulse are going to be key for this. And if the anemia or volume loss is mild, tachycardia may be present, but blood pressure is going to be preserved until there's severe volume loss most often. In the eyes, you might see some conjunctival pallor and scleral icterus in a hemolytic picture again. In the hands, you might see palmar pallor, but this is most often if the hemoglobin's below 70. So obviously that's quite significant anemia. On auscultation of the heart, you might note a flow murmur. This often is suggestive of hemoglobin under 90. In the abdomen, if you note splenomegaly, this often means there's some sequestering going on of the red blood cells. And if you have lymphadenopathy with it, this might be indicative of malignancy or infectious diseases. Without lymphadenopathy, this is most often a hemolytic disorder. So I've got here again, checking lymph nodes, which might be indicative of malignancy. In terms of the musculoskeletal system, if there's frontal bossing, this is obviously quite late stage. And this is due to expansion of the bone marrow as compensation in hemolytic disease. You might see this in sickle cell disease as well, but it's a lot rarer to see these days. You might note some radial or thumb anomalies in conditions such as Fantoni anemia. Now to investigations, and these are going to be incredibly dependent on your other features on history and exam and your suspected differentials. But obviously, in every case of pallor, you're most likely going to do an FBE plus or minus a blood film. And what's going to be most important to look at first is the mean corpuscular volume, or the MCV, determine if it's normocytic, microcytic, or macrocytic. That's going to help you determine the likely etiology. And I've put down this framework or this flowchart from the Royal Children's Hospital, which is super useful. So microcytic is going to be the most common, because that iron deficiency anemia is a microcytic picture. So if your ferritin is above 20, then this is most often not going to be iron deficiency, but also consider that it is an acute phase reactant. So it could potentially be high. You have to consider it in conjunction with a CRP or an ESR. If their ferritin is high, though, it could also be indicative of thalassemia, which is obviously a lot rarer, and you have to take into consideration ethnic backgrounds and family history. But then you might continue along the path of diagnosis for that if that is suspected. So chromatography or HB electrophoresis. If there's a normocytic picture, you're most often going to look at a reticulocyte count. So they are the immature red blood cells. If they're increased, then you are probably suspecting hemolysis, because you're having increased production of reticulocytes in a short period of time to replace those hemolyzed red blood cells. Or it might also be the result of blood loss as well. If they're not increased, you might consider bone marrow hypoplasia, leukemia, or other causes of infiltration. If you have a macrocytic picture, take a look at the folate and vitamin B12 because it could be indicative of a deficiency. Other tests that you might do, as already discussed, a ferritin and a CRP. And the other investigations, as I've said, are going to really be guided based on your FBA results. And this here is just another way of breaking down your FBA. But this framework here uses reticulocytes first. So are they elevated, or are they low or normal, or just slightly elevated? And then after that, taking a look at the MCV and breaking it down into 4 groups. So for elevated reticulocytes and a low MCV, looking at hemoglobinopathies. Elevated reticulocytes and a normal MCV. I've got a big list here, but things like membrane disorders and red blood cell enzyme disorders, some immune disorders, hemoglobinopathies, microangiopathic anemias, for low reticulocytes and a low MCV, iron deficiency, and some other more rare causes. And then for low, normal, or slightly elevated reticulocytes with a normal or high MCV, we've got some more rarer causes as well, like a congenital aplastic anemia, and acquired hypoplastic anemias, and megaloblastic anemia could also be a potential cause here. Okay, to finish up, we'll just run through two differentials, one of them being a really, really common R1 hematological condition and the other one being an R2 hematological condition. I guess pallor doesn't have a lot of matrix conditions to it, but it's still a very important framework to know because it is part of the faculty APEX preparation guide. List of APEX topics, I should say. So it's definitely still important to run through. Okay, as I've harped on about the whole time, iron deficiency anemia being a very, very, very common cause of anemia in children, and the most common cause of pallor as well. But most often that's going to be a severe iron deficiency anemia. So what are the potential etiologies? Obviously, there's a lot. Most common probably going to be due to poor intake or blood loss as well. But we'll break it down into infants, children, and adolescents again. So in infants, it could be because of maternal iron deficiency. So if the infant's being breastfed, they're not absorbing adequate iron because there's low amounts of iron in the mother's breast milk. Could be because the infant's premature. If they're exclusively breastfed for more than 6 months, they're not getting adequate iron through solids. And then again, late or insufficient introduction of iron-rich foods. In children, this could be due to a vegetarian or a vegan diet, or blood loss from GI disorders like Meckel's diverticulum, celiac disease, IBD. It could be because they've had gastric or intestinal surgery, so they're having poor absorption of iron. It could also be due to infection, most commonly chronic infection as well, or other forms of chronic blood loss. In adolescents, again, very similar. It's going to be a vegetarian or a vegan diet, so poor intake, heavy menstrual bleeding being the most common in adolescents with the uterus, GI disorders again, and in extreme athletes as well, that can be a cause. So what are our clinical features? Symptoms and signs may include pallor, lethargy, weakness, poor growth, shortness of breath, a flow murmur as mentioned before. You can actually have hyperactivity or poor concentration in older children particularly. Our key investigations are going to be an FBE looking for a low MCV and MCH, and an iron studies as well, looking for a ferritin less than 20, can be 30 in some labs that's counted as iron deficiency anemia. And as I discussed before, just being really careful because ferritin is an acute phase reactant. In terms of our management and our counselling towards families and children, dietary advice would include increasing the iron-rich foods in the child's diet, so particularly heme sources, which are most often from animal products, so meat in particular, but dairy products as well. And sources of vitamin C, fruits like oranges, kiwi fruits, and spinach as well, because that really helps with the absorption. Avoiding cow's milk altogether in children under 12 months of age, and less than 500 mils per day in children over 12 months of age. And considering a dietitian referral, particularly in children who are or who follow a vegan or vegetarian diet. Oral iron supplementation is incredibly important as well. So 3 to 6 milligrams per kilogram of weight, and continuing these supplements for 3 months after that anemia is corrected. IV iron should be reserved for children in whom there's contraindications to oral iron, who have poor absorption. So, for example, if they had a condition like pernicious anemia, if they have ongoing blood loss or persistent deficiency after 3 months of oral supplementation as well. Okay, a little bit of change of scenery. Um, but the next differential I'm talking about is alpha and beta thalassemia. So, first of all, what is thalassemia? What are they? They're inherited blood disorders, and they impair hemoglobin synthesis by affecting the production of the globin chain of the hemoglobin molecule. I guess what is quite buzzwordy is that they're commonly seen in certain populations, so specifically Mediterranean, Middle Eastern, or Asian populations. Um, and what's the pathophysiology? So at birth, babies mostly have hemoglobin F, which is comprised of 2 alpha and 2 gamma chains, whereas adults mostly have hemoglobin A, which is 2 alpha and 2 beta chains. So alpha thalassemia is when one or more alpha genes is deleted or mutated, and beta thalassemia is when one or more beta genes is deleted or mutated. And as you can see, both of these are mainly going to affect that adult hemoglobin. So at birth, if beta thalassemia is present, there may be very minimal symptoms or signs, even if it is a more severe form of beta thalassemia, whereas alpha genes or alpha chains are present in both hemoglobin F and alpha. And hemoglobin A. So they're going to be present both at birth and then later on as well in adulthood. In terms of the clinical features, there are different phenotypes of both alpha and beta thalassemia, depending on the severity and what the deletion or mutation is. So, for alpha thalassemia, a silent carrier is when one of the alpha genes is deleted. And so, most often, there's going to be no symptoms at all. But you might have a slightly lower hemoglobin or MCV, but this could also be normal as well. That's why it's called a silent carrier. Thalassemia trait is when there are 2 deletions of the alpha gene. This is most likely going to be asymptomatic, but you're probably going to get a bit of a microcytic anemic picture. So I guess so far the takeaway is that thalassemia is associated with a microcytic picture. HBH disease is when you have 3 deletions, and so you're going to get quite a mild to moderate anemia, and you're going to get more severe anemic symptoms as well. HBH constant spring, I think, is something that you don't have to worry about, but alpha thalassemia major is when you have the 4 deletions of the alpha genes, and so this is going to result in hydrops fetalis, which is most often not compatible with life. In terms of beta thalassemia, normal is obviously when we have 2 beta genes. Beta thalassemia trait is also what's known as thalassemia minor, so it's asymptomatic, and you might sometimes get a microcytic hyperchromic picture. Beta thalassemia intermedia can be quite variable in severity. It can be a mild to moderate anemic picture, but you might also get a bit of extramedullary hematopoiesis to help make up extra hemoglobin, and you might get some iron overload as a result. And I think this can also occur because these patients are most often going to need regular blood transfusions, and as a result, if iron chelation therapy isn't given, then they're going to have iron overload. And then beta thalassemia major has a picture of severe anemia. So they're transfusion dependent. Extramedullary hematopoiesis is definitely going to occur, and iron overload as well. So regular chelation therapy is needed. In terms of the investigations, obviously an FBA and blood smear is going to show a microcytic anemic picture in terms of the MCV. You're going to have, I think that should say, an increased reticulocyte count, because there are going to be a lot more younger blood cells. You might do a hemolytic screen to rule out hemolytic anemia. Iron studies may also occur as well initially if you find a microcytic anemic picture, because obviously iron deficiency is going to be a lot more common. And interestingly, iron deficiency may cause a false negative on HB electrophoresis, and increased ferritin may actually be the picture because of the frequent transfusions, as we spoke about before, hence the need for iron chelation therapy. Beta thalassemia can be diagnosed by either HB electrophoresis or chromatography as well. But interestingly, for alpha thalassemia, DNA testing is actually required to formally diagnose it. First of all, other differentials should be ruled out. And it's also used, as you might know from if you've done your O&G rotation, for pre-pregnancy partner carrier testing. So what's the management for thalassemia? Often for carriers, no treatment is required. And as spoken about, it might just be a consideration in pregnancy planning, particularly in determining if the partner is a carrier, because obviously that then is an increased risk if both people are carriers. For intermediate and major disease, or in alpha thalassemia, we've got HBH disease. These patients often require regular blood transfusions, iron chelation therapy to prevent overload. If there's a lot of splenic sequestration due to the extramedullary hematopoiesis, splenectomy may need to occur. And an allogenic stem cell transplantation might occur as well. So that pretty much wraps up all of the content. In terms of the resources I used to put together this presentation, obviously, as I'm sure you guys are very, very, very aware by now, the Royal Children's Hospital clinical practice guidelines are great. There's one on anemia. I know it's not specific to Pella, but it's a great resource in looking at an FBA and then working out the pathway to take from there in terms of investigating Pella or anemia, specifically, and working out the cause. Up to Date has a great resource on the diagnostic approach to Pella in children. I think it's a British resource, so just take that into account. Obviously, management guidelines might differ a little bit. The American Family Physician has evaluation of anemia in children, which is more so good for differentials, again, because it's an American resource. You have to be a little bit careful when looking at investigations and management. And then there is a resource called Pella Anemia from the University of Calgary, which I think is Canadian. So RCH CPG is going to be the best one to look at, but the others can also be good as a framework too. Well, that wraps up everything for this installment of the Approach 2 series. As always, if you have any questions, please, please, please feel free to reach out to us on our socials, and we'll get back to you. Or if you have any suggestions for any additional Approach 2 videos that you would like to see, please reach out as well. We will aim to do about 5 or 6 of these throughout the year, as they're a new resource, and obviously the Apex is new for this year. But yeah, would be keen to hear from you if you have any questions, comments, feedback at all. Thanks so much.